Okay, let's start. Okay, the next thing is how to remove a foreign body. Okay, so the first thing is you have to make sure that if it is an insect, you have to kill it with lidocaine 2% or olive oil or mineral oil or alcohol drops. This is not so preferred, so basically you should go for the olive oil, mineral oil, okay, or lidocaine. Then strange it out by water irrigation or olive oil. Okay, so you have to make sure that uh, it doesn't damage the tympanic membrane. Now, if there is seed or beans or pea, I told you you have to use hook. Okay, I showed you the image. So you have to go for the rapid access, not urgent. This is not urgent. Okay, so to ENT to remove it by suction with a catheter or by hook. Okay, you can suck it out, or you can use hook. Hook is very good. Okay. Now, never irrigate or instill oil in such cases or in the organic matter, seeds, beans, and pea. It will swell the. So you know that if a bean takes the water, okay, if you irrigate anything and it absorbs the water or something or oil, so it will swell. It will swell. Okay, organic matter can absorb oil, so it can swell and it will further create a problem for you. Okay. One thing more, I want to tell you when you should refer to ENT. Okay, when should you refer to ENT? So you should refer to ENT if the patient requires sedation. Okay. Oftentimes the question comes with the start like autistic. Okay, autistic or non-comforting child, or the child is not supporting. Okay, so then you have to go for the ENT department to sedate the patient with general anesthesia. If there is any difficulty in removing the foreign body, okay, so if there is any difficulty, okay, you cannot, you are a GP, okay, and you cannot okay, so you cannot remove the foreign body, so you have to send it to ENT department. The next thing is if the patient is uncooperative, like I told you with like autistic or uncooperative child. The next thing is if the tympanic membrane is ruptured, if the tympanic membrane is perforated or ruptured, okay, then you have to refer it to ENT. So any difficulty, rupture or perforation of tympanic membrane, autistic, uncooperative child, or if any adhesive is in contact with the tympanic membrane. So suppose this is a tympanic membrane, and there is you have or the child has instilled some foreign body which is adhesive or in contact with the tympanic membrane, then you have to refer it to ENT department. Okay, okay, that's it. Now let's move further. What is super glue? Super glue, it could be removed manually. It is a glue basically. Okay, so if the child puts or instills glue inside the ear canal, so what you have to do, it could be manually removed 1 to 2 days after desquamation. Okay, manually by hand, or refer to ENT if the eardrum is involved. If suppose the glue is attached to the eardrum, then you have to send it to the ENT. If there is air wax built up, a few drops of olive oil to soften hard wax. This is something else. Air wax means that the wax which is normally being produced in your ear, okay, and it is attached with the tympanic membrane, or it is very hard. So you instill some of the olive oil drops to make it soft, okay, because the wax will absorb the olive oil. It will get softened, and then you can take it out. Now the batteries, if there are any batteries, refer to ENT as they should be taken out within 24 hours, okay, because they are dangerous to the ear canal. So again, batteries should be referred to ENT. Any spherical object like pencil, rubber, removed by hook. Okay, I told you Spherical plus hard objects removed by hook. Okay, and soft object should be removed by alligator forceps. Now, next thing is, if any object from these is intellectually disabled, I told you disabled patient or uncooperative children like autistic remove under the GA by ENT or person, referral to the ENT in the following situation. Here you go. When you should refer the patient. If the patient requires sedation, sedation means GA, general anesthesia. Okay. If there is difficulty in removing the foreign body, I mean uncooperative child, uncooperative, difficult patient to deal with. If the patient is uncooperative, with a person with autism, mental retardation, very young child cooperative. If the tympanic membrane is perforated, if an adhesive superglue is in contact with tympanic membrane. Okay, so you can try to remove the glue, but you can damage the tympanic membrane. So it's better to refer the patient to ENT department once the tympanic membrane is involved. Remember. Example number 1, an autistic child being stuck. Okay, now in normal child you can just go with the hook, okay, because it is round and hard object, but this is autistic child, so you have to go to perform a GA, general anesthesia. So for that you have to send the patient to the ENT department. A 5-year-old with a pea stuck inside while eating dinner, his tympanic membrane is intact with a wax covering it. Okay. Now, there was not an option with suction with a catheter or remove by HEC. In this case, pick routine referral to ENT. Routine, not urgent referral. Recently asked question. Okay. So this is not a big of a problem. This tympanic membrane is intact with a wax covering. So wax is covering the tympanic membrane, but the wax seems to protect the tympanic membrane. Okay. And the B is here. So here is a P. Here is a wax and here is tympanic membrane. Okay. So what you can do is there is no then an option with a suction with a catheter or remove by hook. So these two options are not available. You can remove it by hook or with a catheter, or if these two are not present, then you can say that okay, the tympanic membrane is not damaged or being damaged by the P. So then you can routinely refer to ENT because you are unable to remove the P out of the patient's ear. I told you here that any difficulty, okay, any difficulty, or you are not able to suck it out or okay, remove it out. Okay, example number 3, a child presents for the pencil rubber. It is hard and it is spherical, so you remove it by hook, and I showed you the hook. Okay, this is the hook. Okay, how you remove it? Like this. Okay, here you can see they are removing the hook. Okay, okay, let's move further. Okay, it's done. Now here you can see here is the nasopharynx, here is the oropharynx, and here is the laryngopharynx. Okay. Now let's move further. So the next one is the nasopharyngeal carcinoma. Okay. Nasopharyngeal carcinoma. Okay, so you can see nasopharyngeal carcinoma will. So here is one ear, here is the another ear. So suppose this is a nasopharyngeal carcinoma, it will block the eustachian tube. Okay, it will block the eustachian tube, and it will lead to otitis media and all of that stuff. And it can progress and metastasize to the nearby objects, nearby organs or something. Okay, now let's move further. So first of all, nasopharyngeal carcinoma is a squamous cell carcinoma. Okay, squamous, and it is the as you know, the nasopharyngeal. It means this is a carcinoma of the nasopharynx. Squamous cell carcinoma of the nasopharynx. Okay, the nasal part of the pharynx, or the pharynx part of the nasal. The next one is that it is very rare. Okay, it is very rare in the southern part, and it is mostly associated with the EB virus, Epstein-Barr virus. Okay, Epstein-Barr virus can lead to nasopharyngeal carcinoma. And what the patient will present you with. So the first one is, this is the head, okay, this is the cervical bones. So there will be cervical lymphadenopathy, okay, and there will be local otalgia, because I told you that, look, this is one ear and this is one ear, okay? The other one. Here is a nasopharynx. Here the tumor is growing, okay? So it can lead to the blockage of eustachian tube, okay? When the eustachian tube is blocked, okay, what will happen? Here it will lead to otitis media and infection in the middle ear, because the secretion cannot come out. So there will be backflow of the fluids, okay, and all the objects that are secreted by the middle ear. So there will be otalgia, okay. Otalgia means ear pain, okay, and there will be one-sided serous otitis media, okay, and to which side it is more concentrated, that side will be affected more. Then you will have nasal obstruction. Why? Because it is at the end of the nasal. You can see this is the nasal part, okay. If it is present here, it can block the nasal part, okay. So there will be nasal obstruction, and there will be discharge coming out of the nasal, which is called as discharge or epistaxis. So epistaxis can come or discharge can come, okay. Now again, because there are some other cranial nerves passing hereby, suppose like the cranial nerve 3 and cranial nerve 4, okay, it can also affect these two nerves, causing the cranial nerve palsies of cranial nerve 3rd and 4. Okay. 4th is SO4, superior oblique in the eyes. Okay. That's it. So what you have to do is you do the CT scan and you can do MRI, both. And the treatment will be radiotherapy. Now let's read out. Swollen cervical lymph nodes, painless swelling, painless. This is very important. And lump in the upper neck. Okay, there will be lump. Eustachian tube obstruction. I told you otitis media, epistaxis, recurrent nose bleeds, nasal obstruction, other conductive hearing loss, tinnitus. Okay, so the air cannot basically pass through the air conduction will be less than the bone conduction will be. So there will be conductive hearing loss on the same side where it is growing. So risk factors are Epstein-Barr virus. This is very important. Smoking and alcohol. Epstein-Barr virus will lead to Hodgkin lymphoma and nasopharyngeal carcinoma. This is very important. So it can lead to these two carcinomas. Tonsil carcinoma. Okay. So now let's move on to the tonsil carcinoma. Okay. Now the tonsil carcinoma is the carcinoma of the tonsil. This is again the squamous carcinoma, okay, squamous cell carcinoma. And the risk factors are smoking and the HPV, okay. Here the nasopharynx, the risk factor was EBV, Epstein-Barr virus, but here there will be HPV, human papilloma virus, and alcohol. Smoking and alcohol are present in both. Okay, let's move further then. What have they told us? Persistent sore throat over weeks, progressive hoarseness of voice, dysphagia and painful swallowing. Now you can just imagine that here are the two tonsils, okay? Here is the uvula and here is the tongue, okay? So if you are suffering from tonsillar carcinoma, it will be enlarged. It might be on one side or both, okay? So when it is enlarged, you will have dysphagia and painful swallowing, and it can compress the larynx down below by metastasis. So there will be hoarseness of voice, and there will be persistent sore throat. Okay, there is a difference. The nasopharyngeal was non-painful. This one is painful. Okay, you are having persistent sore throat. Now, for feeling of persistent lump in the throat, palpable lump on the anterolateral portion of the neck. So this is the neck, like the sternocleidomastoid muscle. It is anterolateral. So anterolateral, you can see there will be palpable lump. The absence of the weight loss does not exclude the tonsil cancer. Okay, it means that there will be weight loss. Sorry, there will be no weight loss. Tonsillar cancer spread to mandible. I told you in the above slides, here are the two tonsil. So below the tonsil, there is mandible. So it can directly spread to the mandible. This question is very common in the exams. Pain in the throat, there will be teresmus because it is going to the mandible, so it can cause the lockjaw or spasm of the jaw muscle, causing the mouth to remain tightly closed. One important differential diagnosis is quinsy. Okay, in quinsy, I already told you, it can also cause the lockjaw. Peritonsillar abscess usually presents after a history of tonsillitis or sore throat for several days. So quinsy, that is peritonsillar abscess, it also have the lockjaw, and it can occur as a complication of the recurrent tonsillitis. Okay. Now here is the quinsy. Okay. In quinsy, which is peritonsillar abscess, presents with a severe teresmus, which is lockjaw, spasm of the jaw muscle, dribbling of the saliva. So one thing is for sure, that tonsil leads to lockjaw. Okay, and if it is tonsil cancer, it can spread to mandible. Okay, so mandible is very near to it, and it loves to penetrate there, and it loves to involve the mandible as well. Dribbling of saliva, otalgia, cranial nerve 9, glossopharyngeal nerve supplies to both ears and tonsils. So the nerve which is supplying both the ears and the tonsils, so it just involve this one, okay, in peritonsillar abscess. Hot potato wise, it means like if you put a hot potato in your mouth, okay, and then you try to talk. If you now just imagine if you put a hot potato in your mouth and you try to talk, with your voice will be a bit hoarse. There will be a bit hoarseness in your voice. That is called as hot potato. And there will be uvula deviation as well, because it is growing, so it will push the uvula to the other side. Now, Plummer-Vinson syndrome, this we already discussed. There are basically some webs, okay, in esophagus. This is esophagus, so mucosa will come out like this, okay, because of the iron deficiency. So this is called web, esophageal web. So it can lead to dysphagia, okay, dysphagia. And you can see other features of iron deficiency as well, like glossitis, dysphagia, and other things. So it is very common risk factor for oropharyngeal carcinoma. Okay, so you have to exclude the risk. It is common in postmenopausal women, okay, because they are lacking iron. Now again, Patterson-Kelly syndrome or sideroblastic dysphagia. This is same, okay. These are also the names of Plummer-Vinson syndrome. So post-cricoid web, iron deficiency anemia, glossitis, chylonychia, like spoon-shaped names. Okay, spoon-shaped names are observed in iron deficiency anemia. You have to do balloon dilatation. So this is the esophagus. You have to balloon out the so to dilate the webs in the esophagus. Okay. Okay. The next one is paranasal sinus tumor. These are the two eyes. Okay. So sinuses are basically frontal. Okay, frontal sinus, and then maxillary sinus. Okay, and then ethmoidal hair. Okay. Now, based upon the position of the paranasal sinuses, okay, whatever it may be involved, okay, So if suppose this is involved, okay, there is a tumor in your maxillary sinus, so it will grow further, and it will lead to the blockage of the duct, which drains the tears. Okay, there is a duct which drains the tears into the nose, so it will block all the space over here. Okay, so you will feel heavy there. You will feel heavy feeling. Okay, and you will feel that your head is falling down. Okay, whenever you look down or you bow your head. Okay, so your body will seem like your head is falling down. Okay, so it will block all the space over here, and it will block the ducts of the tears. So there will be no nasal obstruction. There will be history of chronic sinusitis. Okay, because again and again your ducts will be blocked, and there will be no secretion going out from the sinuses into the nasal cavity. Okay, so when your secretions are not getting rid of the sinuses and going into the nasal cavity, those secretions can get clogged up, and it will lead to infections. Okay, and these infections can then lead to chronic sinusitis. So there will be history of chronic sinusitis. If the orbit is involved, epiphora will be there. Okay, so suppose if the tear duct is blocked, then you will suffer from epiphora, excessive watering of the eye. Okay, and you will also see diplopia, and there will be pressure symptoms. If you just push this space of the maxillary sinus or push the space of the frontal sinus, it will tell you which area is more bothersome and painful to touch. Okay, and then blood could also be seen in nasal discharge. Okay, so if the patient comes to you with chronic sinusitis, okay, chronic sinusitis, then you have to exclude out the paranasal tumor. Okay, now let's move further to otitis media. Okay. Now, what is otitis media? So first, I would like to tell you there are two types of otitis media. Okay, one is called as acute, one is called as malignant. Okay. So acute just involves the air canal. Okay, and malignant, it involves the mastoid. Okay, it mostly is present in immunocompromised. Okay, and the most common bacteria is Pseudomonas, which is greenish in color. Okay, and it can also go into temporal bone. So it will present to you with cranial nerve paralysis of 9, 10, and 11. 9, 10, and 11. Okay, and there will be severe ear pain. Okay, and there will be foul smelling. Okay, because Pseudomonas is the foul smelling. This is called as malignant. Okay, malignant otitis media. Okay, that's it, I guess. Okay, now, so because look, this is the middle ear, this is the inner ear, and this is the outer ear. Okay, so there is infection over here. Okay, so if it leads down into the mastoid bone and up into the temporal bone, or involves the cranial nerve 9, 10, 11, or there is severe pain. Okay, and a lot of the area is being involved, and there is foul smelling discharge as well, and greenish discharge. Okay, so you must expect malignant otitis media, and the patient will tell you his history of being immunocompromised. Now, if the patient is having acute symptoms, okay, and there is no other structures involved, this might be the simple acute otitis media, which is mostly present in ear canal. Now, so how will the patient present to you? Okay, the patient will present to you with hearing loss. Okay, and one more thing, there could also be some balance problem. Okay, it mostly is present with the, I'm talking about the otitis media, acute otitis media, okay? Mostly 2 years of age. The patient, the young guys, because you know that eustachian tube is much more horizontal in the babies. So because of the horizontal eustachian tube, it is most likely that the milk which is given by the mother goes into the eustachian tube and goes into the middle ear and causes otitis media. Okay, but in adults, this eustachian becomes more, this angle becomes more acute and vertical. So we don't often get otitis media so commonly. So they get, because of the horizontal eustachian tube, they get otitis media very common at the age of 2 years. Okay, now mostly there are two things. Okay, one is otitis media with effusion, one is simple acute otitis media. Okay, both of them, now I'm just trying to concentrate on their similarities. Okay, both will tell you that acute otitis media will present with fever, pain, okay, all that, but both will have conductive hearing loss, okay, because there will be obstruction in the ear and air cannot pass efficiently, rather bone can pass efficiently to the inner ear. Okay, so bone conduction will be greater than air conduction, so you will have conductive hearing loss. Now, so there will be earache, otalgia, usually follows upper respiratory tract infection or tonsillitis. Okay, I told you why, because the tonsillitis bacteria will go upward into the eustachian tube and it will create mess in the middle ear, and it will, so this is the tonsil. From tonsil into the eustachian tube, the bacteria will go to middle ear. And then fever, vomiting, irritability, same. Okay. Now, tympanic membrane might be red, yellow, or cloudy. This is very important. Okay. Red, yellow, or cloudy. Red, yellow, or cloudy. It may be bulging, perforated, or without purulent discharge. Now, the thing is, if the patient presents you with pain, okay, and you see the tympanic membrane and it is bulging, okay, it is bulging, this means that there is acute otitis media in the middle ear. But if the patient presents to you and he says to you, he tells you that a few days ago I had severe pain, okay, I had severe pain, but now the pain has subsided. And when you check the membrane, the tympanic membrane, it is being ruptured. Okay, now the fluid or the pus is oozing out from the ruptured tympanic membrane. Whenever the tympanic membrane is being ruptured, so the pressure symptoms are being relieved. So there will be decreased pressure symptoms. So the patient will feel no pain. Patient will feel no pain. Why? Because the pressure symptoms are relieved. Okay, so ruptured tympanic membrane alleviates the pain. This is the key. Okay, so usually viral requires an adjacent support treatment only if the signs of bacterial, it is high fever or cervical lymphadenopathy, oral amoxicillin. Okay, okay, now we will be talking about the otitis media, otitis externa. Okay, if you have any question regarding the otitis media, you can ask. Okay, so here you can see that from here to till here, we are dealing with external ear. If the patient goes to bath or he goes to somewhere or swimming, and that is not a good area to swim, okay, so the bacteria from here to here will go and they will proliferate here. So the patient will come to you and he will say, first itching started, and now I'm suffering from pain. First itching and then pain. This means we are dealing with otitis externa. And just ask him for the history as well. He will tell you that he has gone or he had gone for swimming to some area. Okay, so here you can see there will be redness, itching, inflammation and swelling of the ear canal. Maybe some discharge is also coming out, okay, but the eardrum is intact. Now, if you look, if the eardrum was ruptured and the pus is oozing out and the patient is feeling no pain, this means that he is having the ruptured otitis media. Okay, if the tympanic membrane is intact and he is having pain, and when you look into the ear canal is empty and there is no symptoms in the ear canal, this means you are dealing with acute otitis media. Okay, now if the patient, if you see the patient and if you closely watch the ear canal and there is no perforation of the eardrum, but still there is pus coming out, or there is some discharge coming out, then you can expect the otitis externa, because it is not coming from the inner middle ear, it is coming out from the middle ear. Okay, now next, what is otitis externa? Okay, otitis externa is basically a history of swimming, high humidity travel, painful ear pus or serous fluid inside the ear canal. Okay, and there will be no rupture. Okay, and serous discharge will be there. Tragal discharge. Tragal is this part. Okay, there will tragal will have pain. A combination of acetic acid, aminoglycoside, and topical corticosteroid will be given. So what you have to give is three things. Okay, acetic acid 2%. This is the first line. Plus topical steroid, or if you cannot use it, then you can use aminoglycoside, or you can use all three. Look, avoid aminoglycoside if there is tympanic membrane perforation, as it is ototoxic. If there is tympanic membrane perforation anywhere, okay, not otitis externa or media, anywhere, you don't use gentamicin or aminoglycoside because it is ototoxic. Rather, you should use Cipro. Okay, Cipro is used where there is rupture. Okay, and this rupture is not so common. Okay, in otitis externa. So ciprofloxacin drops should be used instead. The treatment in exam usually topical gentamicin or topical gentamicin plus hydrocortisone. If these were not an option, pick acetic acid. So first is acetic acid, okay, 2% plus hydrocortisone, or second is gentamicin plus hydrocortisone. Okay, if ruptured, then you should go for the Cipro. Okay, one thing more. Okay. Now this is ear in trauma to the ear. Okay, trauma to the ear. Now trauma to the ear means so first thing is when you have tympanic membrane rupture. Okay, a patient comes to you with tympanic membrane rupture. So what are you going to exclude? The first thing could be trauma, barotrauma. Okay, barotrauma or direct trauma. Baro means pressure. Pressure trauma or direct trauma could be because of the high pressure sound, or could be direct trauma, someone slapping. Okay, or it could be because of the infection. It could be because of the infection. The infection is the most common cause of the tympanic membrane rupture, most common cause. But then comes the trauma from the barotrauma or direct trauma. And in the trauma, you can see some bleeding from ear. Okay, there will be intense otalgia, ringing inside the ear, tinnitus, temporary decrease hearing, conductive hearing loss, but there will be bleeding. Okay, this is very rare in infections. Okay, now whenever you see a ruptured tympanic membrane, okay, it will heal in 6 to 8 weeks, 6 to 8 weeks, okay, itself. But if it is very large rupture, okay, if the rupture is very large, or if it doesn't heal itself, then you should go for the myringoplasty. Myringoplasty. Myringoplasty is basically the plasty of myringo, like the tympanic membrane process. Okay, that's it. So during fight, slap, intense otalgia, decreased hearing, conductive hearing loss. Why? Because there is blood coming out, or your tympanic membrane cannot transfer the air accurately. Okay, the first investigation is otoscopy. Suspected perforated eardrum. Otoscopy is the small thing from which you can see into the ear. Now, history of travel present with the ear ache and pulse. Now, travel means swimming. Ear ache and pulse in the ear canal. Ear canal means otitis externa. Management. So first you go for the acetic acid, then topical gentamicin, then topical gentamicin plus hydrocortisone. England guidance recommend otitis externa, acetic acid. This is the first line. For 7 days, TID. So you give spray, okay, 3 times a day for 7 days. 2%. Then comes the neomycin sulfate plus corticosteroid. You can also use this one, 3 drops, second line. Okay. Neomycin or gentamicin, anyone you like, minoglyphosate. The next one is upper respiratory tract can be followed by acute otitis media, severe pain in neck. Yes, this is common. I told you. Mandibular lump and any salivary glands masses need to be investigated by ultrasound guided fine needle aspiration. For example, free and mobile submandibular mass that flow rapidly with skin induration FNAC. What are we expecting? We are expecting some submandibular cancer. Okay, let me explain it to you. So let's go to the salivary glands. Okay, first I should briefly tell you what are salivary glands. So salivary glands are basically 3. One is called as parotid, one is called as submandibular, the other one is called as sublingual. Okay. So the most tumors are from the parotid. Tumors are mostly from parotid, and mostly stones are from the submandibular.